Hello and welcome to the Postpartum Podcast. My name is Melissa Loescher and I am your host for today's episode. And I will be joined by Dr. Sarah Kalia, in which we'll be discussing the bioethical issues behind postpartum mental health disorders.
Hi, everyone. My name is Sarah Kalia. I'm a reproductive psychiatrist. I'm the director for the Arizona Perinatal Psychiatry Access Line, as well as the Arizona Pediatric Psychiatry Access Line. This is kind of the project I think I've been slowly working towards without knowing I was working towards it. And I'm sure we'll get into that in the rest of the time as well. Uh, I'm a bit of a nerd. I love fantasy, dystopian, coming of age stuff. So that's also, I think, something you need to know about me if that matters.
Yeah,
Uh, yeah. How are you doing today?
perfect. I'm doing well. Thank you so much for joining us. And what kind of got you interested in perinatal psychiatry in the first place?
Um, I was born and raised in a third world country. Women in general, when it comes to not really highly prioritized. And it was something I realized even as a young girl that women kind of make the society run. Like
Yeah.
there's the invisible labor of women that just kind of makes the family run, the community run, things like that.
hmm
Uh, and then in that sense, I kind of always knew that I would work with women. My mom really wanted me to be an OBGYN, and I just couldn't do it. Hats off to my OB colleagues, but I
Yeah.
have no idea how they do what they do. And so part of this piece of like women's mental health is also the idea that you can kind of work with women at such a critical point in their life. And that impact potential is so amazing. Like it not just impacts the women directly, but like pretty much everything around them in that sense too. So that
Yeah.
that was also key. The need is so high. It is a very treatable and impact sort of condition in that time period, and also the impact is amazing.
Totally agree. Like, just the invisible labor of women, it's not talked about enough because even if you're just a stay-at-home mom, it's not just a stay-at-home mom. You're like actually making sure everything is running smoothly and taking care of everything. And then on top of that, the women who take care of their kids and work, like it's the mental load is so much for women.
And I feel like now the shift is happening where it's getting talked about,
hmm
but that's it. Like it feels like it's just lip service now to be like, yes, I accept the mental load and continue. And I'm
Right.
like, well, and so I think now there's a little bit more of like, oh, we talk about it, sort of, and we're like, oh, you're back from maternity leave. You no longer call maternity leave vacation, but we also expect you to be ready to go. And
Right.
if you need pumping breaks, that's like a little, not really easy for the team, You're
Right.
like, what?
Definitely. So I kind of want to ask about what are the most common disorders that you see women in the postpartum period face, and where do you think they stem from?
Ooh, okay. The most common disorders are depression and anxiety. So
Mhm.
anxiety is actually more common than depression. And for a while, it was just postpartum depression that we were talking about. Anxiety is more common and see it. The other thing to keep in mind is this is a really, really high risk time. So
Mhm.
that postpartum pregnancy and postpartum often framed as like joyful, but clinically it is the highest risk period for psychiatric illness, right?
Mhm.
So trauma will resurface, OCD will come back, PTSD, etc. So you're really kind of seeing things that maybe you dealt with that you put away. They all have a risk of coming back. And then of course specific psychiatric emergencies in that time period.
Yeah.
And to the second part of your question of like where do they come from? They don't come from any one place. Like I don't think we have that sort of pathophysiology cleanly marked out, but it is a scenario of like past psychiatric history, social factors like lack of support, hormonal shifts, severe sleep deprivation, identity changes. It's kind of a little bit of both biologic pieces and, of course, psychosocial pieces of it. And the identity shift is no joke either, right? Like, you need time to develop this new identity. And we allow that, like, say, in adolescence, we're like, yes, of course, you're coming into your own. We give you time to develop the identity. When it comes to becoming a mom or all the layers within it, even if you already have a child, like there's a difference sort of each piece of it. With no room for it. Like you switch now, come back
Yeah.
to work and go forth.
I think it's really interesting that you bring up the identity shift and how difficult that can be for a lot of women to handle because I never really thought about it before, like how monumental it is to just go from like an individual to now having to completely take care and worry about a new child, a new life, and assume this like new role.
I think it's beyond even an identity shift, right? It's a freedom shift. So it's not, it's caring for a newborn. It's becoming a different version of yourself. Your body has changed. Your relationship has changed. Your autonomy has changed. And any one of those scenarios would be difficult, right? Like if you're just your sense of identity shifting, that's different. But if just your autonomy is different, just your relationship is different, just your body. It's
Mhm.
all of those things all at once. And there's really no time to process it because you're immediately responsible
Yeah.
for another sort of human person. And it's a big deal. Like if you already had an identity set in place, you kind of needs time to integrate into this newer version. How can I be a lawyer plus a mom and do all the things that moms do, but also carry sort of that identity? Because the reality of, especially in the US, it is work like you don't have children, parent like you don't work. Like that's just the reality of it. You have both pieces in both lives. So even if when you're home and you're momming, the other part of your life is still there. And so integration needs time and healthy integration needs time too. And often we also make it sound like you just do more. More is like the expectation. And there's no more to give.
Yeah.
I feel like I don't know many women that are like, oh, I have more to give, like a lot more. I'm just sitting on it. Like, do you
Yeah.
know any women like that? I don't know any women like
Yeah.
that.
Yeah. And then how does treatment for this postpartum depression or anxiety typically occur? Like, what's the plan that people go through the whole process?
So when you're thinking about treatment, a lot of the sort of the biggest thing I bump up against is people want to talk about the risk of treatment. And that's a fair thing. But you have to balance it with the risk of disease. And people almost always forget that, neglect that, discount that.
Hmm.
Uh, and the key principle is that the untreated illness is also a exposure. It's also carries risk to both the mom and the baby. And so the core principle of perinatal psychiatry is the risk of it, the risk of untreated disease, because it carries very physical risks to the pregnancy, to the mom, to the neonate, to the longer sort of impact on the child. So it's not without risk, the disease. And a lot of time people will be like, what about the risk of treatment? I'm like, oh my God, that's so terrible. How could you do that to the baby? And I'm thinking, you're doing something
Yeah.
regardless. And I think that piece is something that we bring about and people again give it lip service, but they're sort of stuck in the idea that when you're doing something active, that's something. But the idea if you're doing nothing, that's also something is another big one. And
Yeah.
then it comes to like when it comes to sort of the treatment profile, right? And treatment is always layered. It's never just medication. It's always considering sort of the therapy piece of it. Social interventions are a big deal. Sleep management is huge. You will not find a reproductive psychiatrist who isn't obsessed with getting somebody to sleep to the
Mhm.
point that sleep is medicine. Like
Yeah.
very much sleep is medicine. And so it's kind of taking all of it. But I'll talk about medications in a little bit for a little bit more because I feel like that's where people get stuck.
Hmm.
Um, Most psych medications we have very reassuring safety data in pregnancy and lactation. And we're also, when we're looking at sort of that risk, we're taking like really small effects of medication against the risk of untreated illness. So it's not about eliminating risks. It's about choosing the safest, most thoughtful path forward.
Yeah, I love how you bring up that because mental health is kind of like seen as an invisible disorder, it's really easy for people to just kind of like brush it off and be like, it's okay, like why would, just keep pushing, go through it,
Yeah.
it'll get better without realizing like, no, this is an illness, like this really does affect you and like you do need help for it. And as like the mother, your mental health is, if not the most important in the household.
I think you hit on something really key. That it's so invisible. Like I don't have a cast walking around, so people
Hmm.
forget. But the reality of it is, um, it's really overwhelming. Like for people, and that's also kind of the problem with some of our illnesses, right? Everybody has anxiety, right? But
Yeah.
I'm not talking about everybody's anxiety. I'm not talking about anxiety in that sense. I'm talking about clinical disorder that is anxiety, which by definition with most psychiatric illnesses is it just is to a level that is impacting your functionality. That's
Yeah.
a lot of anxiety. You might have anxiety to be like, oh, I have a presentation to give, I have a podcast to record, I'm a little stressed out. That is not anxiety disorder. When you're talking about an anxiety disorder, it is overwhelming. Your mind is spinning. You cannot find ease. You are not comfortable within your own brain, within your own body. There's no peace for you. And that is kind of a key reality of a lot of psychiatric illnesses. You really, it's very hard to find peace. It's very hard to find contentment, to feel like, okay, I did a good job. Like being a mom is already filled with like doubt. Like,
Right.
did I do enough? My children are going to be serial killers, like all of those
Mhm.
things that you're always worried about anyways. But illness will take it to a whole different stratosphere in terms of how it affects you. Um, and just because you can't see the spin in my head does not mean it doesn't exist.
Yeah, yeah, the risk is very real and it does, how you're saying it affects your everyday capacity. And so the medication you're saying also has a risk, but you don't think that the risk is nearly as great, or how do you kind of balance that?
I think that's a good point. So medications do carry some risks, right? But it does matter in terms of like how you're balancing the risk, and it kind of matters on the individual patient. So, for example, one of the most commonly used medications are SSRIs, that category of meds,
Yes.
and they're associated with low birth weight. And when I say low birth weight, I mean 2 to 3 ounces less, right? So it's not clinically significant. 2 to 3 ounces is
Yeah,
not a big deal when you're talking about an 8 pound baby.
right.
That being said, I have a niece that was a micro preemie, right? If I went to her mom, who was watching her grow ounce by ounce, like,
Hmm.
like in the ICU, and I was like, oh, 2 to 3 ounces less. Oh, heck no, right? Like
Right.
it matters, depends on what your history is, what your particular history of trauma is, etc. If you can't just be like 2 to 3 ounces is the same response regardless of every patient. And so you kind of have to apply the risk to the individual and kind
Yeah.
of be able to explain the risk in a real way, not just like, this is what the research says, because people don't talk in research language. I think the other thing happens is when it comes to translating research, it's kind of hard to do. It's nuanced because psychiatric research is more sort of challenging to kind of piece apart than other places. I Because there's so many other confounding factors, right? Socioeconomic status is a big confounding factor when it
Hmm.
comes to your experience of depression or the fact that you're higher risk of it. And so kind of finding studies that are doing a good job controlling for this confounding factor and then saying this is a real association becomes a nuanced thing. And so it does need people who know what they're doing
Yeah.
for understanding the data. But coming back to your original question of like, what is sort of the risk of treatment? The bigger categories like SSRIs, antidepressants, mostly safe. When it comes to more nuanced medication, like for bipolar disorder, schizophrenia, there's definitely safe options, but I'm not going to blanket say all mood stabilizers are safe because that's just not true. So you need
Right.
somebody who knows the individual meds and the general meds as well.
Yeah. So kind of on this same topic of medication, do you feel like these medications are like well researched and well approved? I know you're saying like it's very nuanced and it's hard to find, but do you think that they do a good job of adequately testing the medication on postpartum women, or is it kind of like overlooked?
God, I don't, do you want to get into the research exclusion of women?
I know, right?
That's a whole different like essay on the history of research exclusion of women.
Yeah.
Okay, so I'm gonna try and how do I answer this without getting into that rant?
Get into whatever rant you need. It's really important to talk about because, yeah, women are so excluded from so much research. Like, there's more research on, I don't know, what is it, male pattern baldness than like endometriosis?
Yeah, well, so we've generally done studies on men and then said this applies to women because women are just smaller men kind of a thing, right? Like
Hmm.
that's a very superficial way of looking at it. But so for decades, we didn't have studies that were looking at women, and then of course, pregnant and postpartum women were routinely excluded. Um, and so we tend to rely more on observational studies, registry data, post-marketing data when it comes to sort of reproductive mental health. And so I think some of the things that really sticks with me when it comes to kind of thinking about the history of reproductive exclusion, women getting excluded from research is we didn't really protect women because that was the idea, right? Like we're protecting women from excluding them from research. We didn't protect women. We just protected ourselves from liability.
Right.
And we created an evidence gap that still shows up for us. And so that's a really big deal when it comes to thinking about like what is how this is going to impact us in terms of treatment as well. So I think I'm going to leave it at that rather
Yeah.
than get into it any further. But when it comes to quality of data, that's a really key question, is like, do we have enough good data to say to talk about the safety? And I think yes and no.
Hmm.
So again, it will depend on what group of medications we're talking about. If we're talking about SSRIs, they're like some of the most studied medications in
Right.
pregnancy, right? So when I talk about SSRIs, I have immense confidence because we have that level of data. However, when it comes to things like newer antipsychotics, we don't have that volume of data.
Hmm.
But we are building it, and there's a lot of programs that are out there, especially the Mass General hotline. Like anybody who's pregnant on a psych medication can call that hotline today, get enrolled. It's very easy. It doesn't matter if you're in Massachusetts or not, and you can be
Yeah.
on, and you can help sort of add to the data that is building, especially if you're on a med that's not, a first line, because that also happens, right? People,
Yeah.
not everybody's going to be on the first line medication because that's just not how this disease process works.
Yeah.
So
Yeah. It's very specific to the individual. Lots of trial and error with medications for sure.
yeah.
How do you feel like stigmas regarding kind of like mental health affect the chances of women seeking treatment? Do you feel like it's like a disproportionately affecting certain groups like ethnicities, socioeconomic status you had mentioned, citizenship status, or kind of how do you want to get into that?
You have like no softballs at all. You're supposed to throw in at least one or two softballs.
Right.
I'm joking. So stigma, when it comes to stigma in terms of postpartum mental health, stigma is one of the biggest barriers to care.
Yeah.
Already, like, let's not even talk about women. Stigma is a barrier to care in terms of mental health in itself, right?
Yeah.
To the point that there is like a plethora of people talking about wellness strategies, and God knows how many journals there are, because we still treat it like, and we also don't even call it illness, right? We call it maternal mental health. Like
Yeah.
in very basic ways, we shy away from the idea that this is illness and this is disease, and we try to like merge together. I'm not feeling well too. I have a real problem.
Hmm.
And because we just really still, on the very basic level, are shying away from the fact that these are really severe clinical disorder level illnesses that we're talking about. So when we say 1 in 5 women have perinatal mood and anxiety disorders, that's clinical level. I'm not talking about baby blues. I'm not talking about,
Right.
that's a high number.
Yeah.
And so, and stigma is one of the biggest barriers to care in the perinatal postpartum period. Women are already like questioning themselves as like new moms. And then when mental health system symptoms show up, I cannot tell you the amount of women that have like, that will sort of bring it up, like, what does this say about me as a mother? Am I not
Right.
cut out for this? Am I gonna like harm my child somehow? And they can't even, and a lot of the times women won't even bring it up, so you have to like go and like dig it out of them to
Yeah.
be like, hey, what is going on? How bad is it? Like, I need to know, because I don't have a blood test I can do to be like, okay, your blood sugar levels are this, like,
Right.
I don't have that. And so there's that very real sort of internal worry about that shame that gets layered. And part of that is backed up. Like there's a very real fear of being judged.
Yeah.
You're not judged, then you're not being taken seriously. And if you are taken seriously, there is that fear that disclosing symptoms, especially when it comes to substance use disorders, could lead to the involvement of child protective services. And that alone can stop women from like speaking up or seeking
Yeah.
help. And I think one layer of your question was like, who does it impact more? And of course, there are certain groups that are impacted more, right? Women of color, immigrant women, those with lower socioeconomic status are often sort of, they have like compounded stigma of like
Yeah.
all of those other pieces
Right.
plus this. So, and that's not just stigma in the broader society, it's also stigma within the healthcare system. And, you can be mistrustful of healthcare systems, you can have language barriers, there's cultural expectations around motherhood. And then, of course, there are scenarios where there are really very real consequences tied to disclosure. And so the stigma is personal, but it also isn't personal. It's almost like a structural barrier all on its own within like your community, within your relationship, within your healthcare system. And so it becomes really challenging to support women. And then as the provider office, you really have to work hard to kind of work towards kind of helping women.
Yeah. Yeah, definitely I can see how intersectionality like just continues to layer more and more on like the barriers to looking for treatment and kind of where it brings women to a place where they feel like they're like invalidating themselves or trying to downplay their own emotions and like the seriousness of it all.
Well, I mean, it's just so simple. Like 33%, Black and Latina women are 33% more likely to experience a perinatal mental health illness than white women.
Hmm.
There are so many like considerations when it comes to like pregnancy related mortality rates are higher in
Yeah.
Black, uh, and American Indian populations. Maternal morbidity is higher. Location will matter. Ethnic disparities will matter.
Yeah.
Um, and so it kind of does. There's many layers to it as well.
Yeah. And so you had also mentioned a little bit how CPS can get involved possibly with cases. What is kind of the framework where the safety is like of higher concern when that step needs to be taken? Like, is there a hospitalization? Is there like rights to the mother taking care of her child? Sorry, it's kind of a lot, very loaded.
Yeah, it would be a risk assessment basis, right? Like just
Yeah.
to make it super simple, just for me to kind of think through it, it would be thinking like suicidality, any thoughts of harm to the baby, active psychosis, or you're unable to safely care for the infant, either due to your physical illness or your mental illness. I think those kind of safety issues would be sort of where that would get triggered.
Yeah.
And that's a very reasonable consideration, except moms don't see it that way, right? Moms are like, I don't know when you're going to do what. And so that becomes kind of a scenario in terms of, especially as it applies to sort of racism
Yeah.
and and racism in the
Yeah.
reproductive health perspective.
And in psychiatric hospitalizations, typically they're like an inpatient stay are very
Mm-hmm.
strict in terms of like what you can do while you're there. Do you see cases where like women are completely separated from their child th throughout the entire time when they're hospitalized, or do they have kind of different rights?
Psychiatric hospitalization is so different from hospitalization that people experience, right? And I've
Right.
taken care of women who are like, I've never been in a hospital, and this is their first time being pregnant and sort of really interacting with the medical system. And even within the medical system, and I say this as somebody who has like family members who are in the health system, psych hospitalization is a different, like just a different concept altogether, right? So
Yeah.
there's voluntary hospitalization, involuntary hospitalization. But a lot of the times, psychiatric hospitalization is because it is that severe. We need to keep you safe
Yeah.
from yourself or because your illness isn't controlled, right? And so it doesn't, it, a very key thing, like in a psych unit, you're not allowed like tubing, right? There's nobody on an IV in a psych unit because
Right.
it's a danger. People are trying to actively harm themselves. And so bringing a baby into a psych unit, you need infrastructure to be able to do that, right? Like you
Yeah.
need somebody to watch the mom, watch the baby, and kind of leave. There is sort of mother baby units that exist outside of the U.S. Like that's sort of part of their continuum of care is a
Hmm.
mother baby unit. We have no mother baby units. North Carolina has like an 8 bed voluntary unit, but even then, the babies come to visit. Babies don't stay together with moms, and
Mm.
so this exists and it can be done in terms of a psychiatric mother baby unit for patients who are not doing well but are not a danger, like but like need support but are not quite like you're psychotic, I can't leave you with a child.
Right.
There's layers to it. It's not like everything is on the same like at 100. It's
Yeah.
just we have them in the US.
Yeah. Do you feel like there's a big need for them and then we should push more for those mother baby units?
There is a big need for them. um of course we need them, but that's also like a thing, right? Like we're like North Carolina. I get jealous of North Carolina often because like they have such a good infrastructure. They have so many brilliant psychiatrists there. They have a reproductive psych fellowship. They have infrastructure,
Yeah.
right? Also, these being all that they are, it's one 8 bed unit, right? So yes, we need things, but we also need things in societies in across the board.
Right. For example, you're saying something like this, like there's not equitable access to it right now. There's one in North Carolina, and if you don't live in North Carolina, it's kind of like, oh well. And there's
Or
only
even
eight
if you do
beds.
live in North Carolina, like
Yeah.
you're not living necessarily close to that, right? Like
Yeah.
I think the people are underestimating how expensive things are,
Yeah.
and, and that impacts everything.
Hmm.
So, uh, if you have to come an hour to get treatment, that's a problem.
For sure.
Child, you have to think about transport and childcare and days off of work. As a working woman, I can tell, like, I don't have a ton of days off. And
Hmm.
I remember when I was in training and I had a very young child and I was a medical intern. I didn't have time off. And my son got sick so much he needed two surgeries.
Oh,
All my time off went to that. You
yeah.
know, and then say if I even wanted to go get care for myself at the time, it would have automatically been like lowest on my radar because baby comes first and then the house comes first and then I'm going to save my time because what if you get sick again? And so there's so many reasons where it gets just pushed away. So as we think about improving care, it also needs to be like, how do we make it so easy for people to access that it's not like an extra step that you have to make at the expense of other things and other
Right.
choices.
Yeah, there's already a great need for the inpatient like units in general, and but also just to go to a simple appointment becomes so difficult when you're yeah having to worry about job and your transportation and who's taking care of the other kids and who's taking this one to school and this whole
Yeah.
thing, and it's just it's so difficult to try to schedule it all. It feels impossible, and it just continues to add to that mental load when you're already not doing well, and then you can't even get an appointment to try to take care of yourself. Like your one attempt to take care of yourself becomes so far out of reach.
And then on top of that, let's think about sort of the structured racism, if you will, right? When you look
Yeah.
at some of the data there, you will find that, um, especially I think it was veteran data that I'm thinking of, or was Black veterans were referred to like LCSW versus white veterans were referred to PhD level. Like it's
Yeah.
kind of in every little thing that
Yeah.
you think about. So it it's all of that, and then sort of the compounding aspect of things in terms of that reproductive justice piece, right? When you look at it from a access to care or economic perspective, women under the federal poverty line have 5 times more unintended pregnancy as
Yeah.
women who are 200% over the line.
Yeah.
There's so many layers to all of it that it becomes kind of it becomes really hard to kind of pull it apart.
Yes. And then, sorry, can you clarify the LCSWs, they are not allowed to prescribe medication, right? They're just more so like counselors
Both
or
of those are counselors, right? PhDs and psychologists and LCSWs, but
mm,
and and you've got great providers in both. It's not about the ability of the provider, it's about how seriously somebody gets taken.
yes, gotcha. And do you feel like, general kind of like PCPs and or gynecologists, do you think that they do a good job of doing those like
Oh, absolutely.
screenings?
I think they do as good a job as possible. I
Yeah.
think we have to also, I think the reality of a PCP's day and the reality of an OBGYN's day is not something that's automatically available to the general public, right?
Yeah.
Like we go in and we're like, this is me. You're like, oh my God, you should care. But like an OBGYN has a 10 minutes appointments, 10
Right.
minutes for each appointment. It's insanity.
So short.
That's ridiculous when you
Yeah.
really think about it and you think about all the things that they're working on and the fact that they're trying to make sure that you have a healthy baby at the end of this pregnancy. And then a lot of the times women will be like, my OB didn't talk to me about it. They didn't have time. They literally do not have time.
Yeah.
That they are set up from the system to kind of fail. And I know so many OBs who just like are taking extra time with their patients. Great. The system does not reward them for it. The society does not reward them for it. I know
Right.
OBGYNs who are running home, getting home late, they also have families, right? Like it's not like
Right.
they don't their own lives, their own children. They don't have to figure out lunches, all of that. So the system is really set up in an almost like ridiculous way when you think about it. So OBGYNs really, I find that I don't think there are any like bad doctors or bad nurse practitioners. Like they're just not. It's just the system doesn't let them really care. And
Yeah.
if you think a 10-minute appointment is good enough for you to get a good psychiatric assessment
Right.
of what your disease is, the severity of your disease, your approach to treatment, that's just not going to happen.
Mm-hmm.
It's not enough for me to get to a point. And for me, like this is what I do, bread and butter. I can't get there in 10 minutes.
Yeah.
While also making sure that your pregnancy and medical pieces of it are all moving along and all the check boxes in the electronic medical record are kind of counted for. And
Mm-hmm.
kind of same with PCPs. PCPs kind of vary in terms of what time they have, but they don't have time. And I think
Yeah.
people approach doctors, clinicians, healthcare providers in a very different way.
Yeah.
You get inbox messages. Yesterday, I got 4 FMLA paperwork requests to fill out because
Mm-hmm.
I just take care of women. So there's a lot of FMLA paperwork, right?
Right.
Like I want to this and that. It took me time to fill out each paperwork, right? I don't get any productivity credit for that time.
Right.
If I were a lawyer, I'd be like, let me bill you for the time. And my lowest amount that I bill you for as an hour, even if I spent 5 minutes on it, I'm going to bill you an hour. We just don't treat, we treat medicine as a business without treating medical providers as business providers because we can't be. We didn't get
Yeah.
into the role to be, but so you just kind of get penalized by the system repeatedly.
Yeah. Structurally, like the system is flawed in the first place. Like across all healthcare
Yeah.
specialties, like the system is flawed. 10-minute appointments are not enough for doctors to really be able to do a thorough enough evaluation. And correct me if I'm wrong, but is it this kind of framework due mostly to like the insurance system that we have in the US? And even with you like filling out paperwork and all that, it's like kind of all goes back to insurance.
Oh, yeah, I'm going to get canceled. So actually, I don't think I know the answer to is the 10-minute back to insurance.
Hmm.
I think there is a lot of misconceptions with regards to how medical systems make money.
Yeah.
And a lot of the pressure is we need you to make money. You see more patients, we make more money.
Hmm.
And then a lot of healthcare costs are rising, right? So there is like what I don't know the correct number, but I think it's like 2 or 3 or healthcare administrators to each healthcare provider.
Right.
And we bring what healthcare providers bring in are sustaining sort of the whole system. And so the push is make more money.
Hmm.
It's no longer, I don't even feel like it's any more couched in the sense of like make more people healthy anymore. It used to be there was a little bit of like care, but it
Yeah.
just very much like where are your RVUs, where's your productivity, where's your clinic utilization at, what are you doing, and then are you actually a good doctor, are you actually a good
Right.
clinician?
Lot to think about for sure.
Very curious if people get that feedback of are you a good doctor, are your patients getting better, are you on, in that sense, if any provider gets that feedback regularly or even half as regularly as they get their productivity and clinic utilization measures. I think structurally medicine in the US is not about health. It's
Yeah.
about disease management and almost a reactive approach to disease management
Yes.
rather than a proactive preventative approach. And
Hmm.
that's a problem,
Yeah.
right? Do you really have to wait? Like if I know a woman has got prior psychiatric history, is going through a divorce, is currently pregnant, has got a shit job, but she's kind of stuck in it because of like the whatever the setup is.
Yeah.
Do I really have to wait until she's postpartum and is in a crisis? Like it just doesn't make sense, right? You
Right.
shouldn't have to wait. But disease reaction doesn't allow necessarily for that. And a lot of times the person has to say, okay, this is not good. And I know the resources. And that's where sort of the inherent community comes in. That's where organizations like Postpartum Support International, Chamber of Mothers, these nonprofit organizations are kind of bridging the gap to be like, hey, are you okay? If you're not okay, here's help. This is
Right.
how you get help. And women are finding help for themselves, for their kids, all of that. Part of the reason we started the pediatric line is because we would hear that. Like once we had the perinatal line, but we would constantly hear, okay, I've gotten sort of care for myself. Well, my kid is struggling. How do I get help for my kid? Because pediatric mental health still ended up being the mom's problem.
Right. Thank you so much for answering that.
And as for the insurance stuff, I'll be honest, like I'm not I don't know the healthcare administration data
Hmm.
well or the insurance piece of it well. So I hope you find somebody who has a better insight into that. But
Yeah.
it really is. it really is challenging also. And I think the other piece that I want to kind of say that I felt like kind of pinged in my head as we're talking about
Mhm.
it is, it's a lot to just do your job as a clinician in the healthcare systems that we have, because there's so many pieces of it. Like
Right.
I have to check this box, and I have to get X credit to make sure that I get not penalized for productivity and like all
Mhm.
of that. And then the healthcare system does need to change, right? And so we need to advocate for our patients and try to get the system to change. But that's hard to do when you have like when you're getting home at 5:30 after seeing patient after patient after patient, because it's these are not easy jobs. Like I can tell you, I can just speak for myself. Like I've had days where I've taken care of rape case after rape case after rape case, like a whole morning back to back. You need a minute. You
Right.
can't walk into the next appointment, but there's no minute
Yeah.
clinic utilization.
Yeah, exactly. It's kind of just like all about numbers and productivity and how much, income is coming in versus actual like success rates and, looking back at how is this healthcare system actually helping the patients versus kind of just throwing something at them and being like, okay, next.
Okay, next. Yeah.
Right.
And so, but also at the end of a day like that, for me to be able to have the mental capacity, emotional capacity to go back and say, we need to advocate for a better system. We need better screening so that we can catch them earlier. We need to expand access programs. That bandwidth needs to exist in clinicians, and sometimes it doesn't exist.
Yeah, it's a lot to take on. Like, it's like this added role that you feel like you need to do, not only because it's something that you believe in, but like you care about it. But it's also like, how do you manage your time in doing all of that? Like, this advocation for these systemic changes, it doesn't come easily, especially because they're systemic. So it's hours and hours of work.
Hours of work, hours of meetings, hours of being appropriate to be like, oh, we need, and like even something basic like paid parental leave, I think would have an impact on
Right.
maternal mental health, paternal mental health.
Yeah.
I'm not saying paid maternity leave. I'm saying paid parental leave.
Yeah.
What? Like both parents need time.
Yeah.
It's a shift for both of them. It's not just the mom. And we need to give both parents time to kind of also reacquaint themselves with each other. Because one of sort of the victims of sort of maternal mental illness is the marriage. The
Yeah.
marriage suffers, this relationship suffers if it's not a marriage, because it's too much.
Yeah.
And you need both of them to have time to figure out how this very different life is going to work.
hmm So kind of on that same point, bringing up how, as a provider, it's difficult to also give time into that. Do you feel like the medical institutions themselves or like medical schools should also be working towards this advocacy of like supporting women during their postpartum period or just advocacy for systemic changes in general?
Absolutely, yes.
hmm
I don't know how that would.
Right, how it would look.
Well, I mean, to me, education is advocacy in some ways, right?
Yeah.
But like med students, residents, psychiatry residents even don't have adequate training on perinatal mental health issues. I think now they're required to have 5 hours. So in a psych residency, that's a 4-year residency. They're required to have 5 hours of education on perinatal mental health. And that's new. And that took years of fighting.
Mm,
And there's a free curriculum set out by this National Curriculum of Reproductive Psychiatry that was spearheaded by a really, really brilliant reproductive psychiatrist.
yeah.
Um, and still it takes a while to kind of integrate that level of change in a specialty that is directly taking care of this population.
hmm
If I had my way, I'd be like required for OBGYN, required for family medicine, required for emergency medicine, required for
Right.
pediatricians, because pediatricians see what, and like that is coming, the shift in terms of training, because once they get trained they can recognize and they can respond to it, right?
Yeah.
So training is improving, but it's still inconsistent, and
Yeah.
so that structured education, I think, is a way to kind of advocate for patients, maybe in an indirect way. It's not a systemic change, but if the providers, the clinicians are more comfortable, then more care will happen.
Right, exactly. Because, yeah, 5 hours is out of 4 years is definitely such a limited amount of time. And, that is a change that schools could make. I mean, they're the ones who kind of make their curriculum and their timing, and it wouldn't be so difficult to implement more time into how important, the
It would be
psychiatric
very
aspect of it is.
It would be very difficult. It's so easy for me to be like bad schools, but it would be so difficult because there are
Mhm.
so many requirements they already have to meet. And
Yeah.
so to add yet another requirement, it feels like it could be
Mhm.
easy. But then you have to also realize, the way I feel about reproductive mental health, I'm sure somebody feels very similar
Yeah.
about, dental health and how that's not discussed in medical schools at all. And it impacts everything, which
Yeah.
is true. And so it's that piece of it too. Like everybody has things that they feel like matter. How do you balance it? And I'm glad that I'm not the person that has to decide how they balance it.
Right.
But I also think that it's one of those things that appears simple, but when the minute you get past that first layer, you're like, oh, it's not simple at all.
Mm.
I wish it was.
Yeah.
It's so nice if there were simple answers in life. But I feel like after like third grade, there were no simple answers left.
Right. Yeah. No,
What
thank you
was the
for bringing
last
that up.
age of life where you were like, oh, simple answers?
I know, probably that was like 5.
Yeah, right. Like even like lunch, okay, you kind of have to be like, did I eat well? Am I enough, got enough protein? I feel more protein peer pressure than I did for alcohol.
Right. I know, yeah. But definitely thank you for bringing that up because I mean, yeah, it is easy for me to say like just more hours, but when there's a million different things that they have to, you know,
Yeah,
learn about and fill out all these requirements, it's like all of a sudden every hour does matter and there's not much left to give.
yeah.
Hmm.
Every hour matters. There's not that much to give. And the people that are fighting for the hours that do have, they're like really, I've met so many super dedicated faculty members that are like, this matters. I don't see what you see, but I'm not supposed to see what you see.
Yeah.
And I think that piece of like I wish there were simpler answers, especially in a something that is so heavily layered and nuanced as maternal mental health. It isn't.
Yeah. So we talked about, how these big systemic changes would take a lot of time and a lot of work and effort, but how do you feel like we could be making changes on like a smaller scale, like how we can support women in their postpartum period as like partners, family members, friends, all of that stuff?
I think support looks like practical help.
Hmm.
I mean, of course, that emotional support is necessary. You listen without judgment, you validate. That's not that hard. Encourage care if possible, and really not let that person feel alone. But a lot of times it also means practical help. Help that mom protect sleep.
Yeah.
Share actual caregiving responsibilities, reduce that mental load. Like if you're a partner, take over one job beginning to end. Your partner does not need to like think about it and execute it. You take it over beginning to end. If your partner is exclusively pumping, God bless that person because that
Right.
is insanity. And I say this as a reproductive psychiatrist. Like take over the cleaning and the pumps. Actual practical help. Defend the sleep, defend the person, and make sure that they're kind of set up for success. Because I will promise you, if they can actually get a little bit of peace and better sleep, it will help everything.
Yeah. Especially because with mental health disorders, like how you were saying, like sleep and rest is so incredibly important because you already feel like you're running on empty.
You already feel like you're running on empty. Sleep is where memory consolidation happens. Sleep is where emotional resolution happens. There's a lot of moms that I've taken care of that didn't come into treatment until like, 2 years later, 3 years later. Like things started when they were postpartum and they come back and they're like, I don't remember anything. It's like, yeah, you didn't sleep for like 2 years.
Yeah.
You don't remember anything. Like, and that's such a shame.
Yeah.
Like that is not something that we can give back to that person, right?
Exactly.
And it's such a poignant, sad thing that you don't remember your child's first steps, and that's just gone.
Yeah.
And it doesn't have to be that way.
Yeah. And it brings up the point how just in mental health disorders in general, a lot of times people will just say like, oh, well, just eat more and have a better diet and work out and sleep better and, engage in hobbies that you enjoy. But it's like, as a mother, how do you do any of that
Oh
with
yeah, I mean the amount of
time?
people that tell me yoga will solve everything, and I'm like, well, okay.
Right.
Um, Yoga is great. No offense, nothing wrong with yoga, but yoga is not a one size fits all. It doesn't work for everybody. And like it's exactly what you're saying, right? It doesn't. You have to make the strategy fit the person. And some of the things that telehealth has been really eye opening for me because there's just because you always like there's patients who will just like reset how you approach things, and
Yeah.
I'm so grateful for them because they're the best teachers in some ways. Like, you know, and I was in training, and it was all this idea of like sleep hygiene and education and this and that, and I was trying to talk to this mom about sleep hygiene, and she's like, Dr. Kalia, I live in a studio apartment with 3 kids under 6.
Oh my goodness.
There is no sleep hygiene. I was like, okay.
Yeah.
I was like, yeah, you're right. There's no sleep hygiene. What sleep hygiene? Like, so you kind of have to like match the solution to the person and sort of these like broad ideas of like what really would I have achieved if I was like, go do yoga, take a mental health walk for yourself, journal. Like, come on. Like it's
Yeah.
not those suggestions are great, and I'm not knocking them. I'm just saying sometimes those are also privileged suggestions, and you need a lot of infrastructure to make that happen. And I'm glad for telehealth because I feel like there's a lot of ease that it has. I can't tell you how many appointments I have in people's cars because they
Yeah.
take a lunch break out of work and they go sit in the car or have appointments or have taken care of moms who are literally hiding in the bathroom.
Yeah.
And so I think the access that telehealth provides is great, but I think also remembering that it really isn't one size fits all. And I think you have to also be very careful in the messaging. If
Hmm.
you only ate better, because I think the flip side of that is if you only took care of yourself and ate better, you would be okay. And that's not the disease.
Yeah.
This is like, that does impact the disease, but there's real hormonal shifts at play. This is a real neurobiological considerations at play. You need treatment as well. And so I want people to be very careful in terms of like how they phrase those suggestions because they can have that little layer of like, mm-mm.
Yeah. It's kind of just discrediting how much like physiological goes behind mental health.
It's implying you had control, that if you did better, you wouldn't be here, and sort of it's like your own fault. Like I'm not
Yeah.
saying everybody does that, but I think there can be a layer to that. Like that's a conversation I have with significant others and partners that I come in. So I'm like, hey, how are you gonna say she looks worse and is
Right.
not doing well? You're gonna have that conversation, and like I literally have to tell them, do not say, have you taken your meds today? Don't say that. It
Yeah.
doesn't.
Right.
And I don't think that they mean it out of like any like, oh, you bad person, you're unmedicated, that's why you're ragey. Or are you, it's the same thing as are you on your period? Is that why? Like,
Right.
no. So I think language is a really, really key way in which we address stigma. Um, and it's kind of in that level of and like in kind of how we say everything.
Yeah.
Um, and again, like I'm not taking anything away from like infrastructure and support and sleep and walking and yoga, none of that. But it's not the whole answer. It's part of the answer, and the answer has to fit the problem. And in
Yeah.
some cases, it won't fit.
Yeah. No, I definitely agree that like language is so important and it's definitely something that I feel like if partners and family members and just support systems in general were better educated on that it honestly would make such a big difference because when you're dealing with depression and anxiety, a lot of it is so mental that like yes, the exact words that you use do matter as to whether I'm going to spiral or not.
Well, yeah, and I think we also dismiss sort of the labor involved in all, right? Like I will tell you, um, as a 2 physician household, both of us in residency and internship and training, and a 2-year-old and no family nearby, my mom would be like, you gave him chicken nuggets again? Like, woman, the labor involved in making a nutritional meal from A to Z of like having the supplies, having the time, putting it together, storing it, and
Right,
providing it. There's a lot of labor that went into this nutritional meal. He is fed, we're good,
right. Yeah.
right? Like, you are welcome to come feed my child. But I think that piece of it also is like you have to think about like that person's whole day. And a lot of moms that are now working there, and the data is there, right? Like in terms of like the labor of men versus women in households where both partners work, that it's disproportionate. Make
Mhm.
that proportionate. If you're like trying to advocate for your partner, let's be proportionate there. That could be an easy fix.
Right. Make some changes.
Make some changes. Make your partner's life actually easier.
Yeah, definitely agree. Alrighty, so any final thoughts? Because I'm basically wrapped up on all questions. Anything that you feel like you want to share? Anything that you feel like is important for people to know that they should think about?
I think maternal mental health is foundational, right?
Hmm.
To to the woman, but also to the family, to child development, and to community. So if we don't pay for it in a very literal way in terms of figuring out care for these patients, figuring out systems in terms of supporting maternal mental health and treating maternal mental illness, we will pay for it later in
Right.
pediatric mental health and pediatric mental illness, and that exists. So when we're supporting mothers, and even if you can't find the case for it emotionally and for the fact that that person needs it, if you're primarily looking at it from a dollar perspective, it's savings in
Yeah.
terms of treating, because you're not treating an individual, you're shaping the health of the next generation.
Yeah.
And it just, to me, it's very like basic common sense, but I also know that I have a very narrow lens when it comes to that perspective. And also, please forgive me if some of my rants are inappropriate that I've
No,
gone through.
I don't think so at all. I think you did such an amazing job of explaining everything and kind of giving this new perspective on something that is, so nuanced and not talked about enough. And when there's systemically so much wrong, I don't think that there's any problem with you ranting.
Yeah, I'm hoping that.
All right, well, that is perfect. I want to thank you again so much for this call. I was so informative and it was so nice talking to you.